Starter, start one. Uh, uh, we are trying to cover one topic today, that is Menieres disease. So we'll try to understand about etiology and pathogenesis, clinical features, and management, which includes uh, medical management and surgical management. And later on, we'll see what is the prognosis like. So a lot of history is there about this case. The French physician by name Proctor Meunier in 1861 first described the disease. So disease is named after him. There is two entities. One is Meniere's disease, other is Meniere's syndrome. So definitely not much of difference, but for the sake of syndrome means it contains two or three components. Disease is probably variable. There is not much of much difference between the manifestations. And by definition, in 1972, the American Academy of Ophthalmology and Otolaryngology's Committee on Equilibrium defined the Meniere's disease as follows. It is a disease of inner ear characterized by deafness, vertigo, that is giddiness, and also tinnitus, that is noise in the ear, which has pathological correlation in distension or hydropic distension of the endolymphatic system. So, endolymphatic hydrops is another name being given, so thereby it will result in deafness, vertigo, and also tinnitus. And in addition to that, fullness of the ear also being added to this entity. So, what are the variants? There are some variants of the Meniere's disease has been mentioned. So there is something called atypical Meniere's disease, and next comes is Lermois syndrome. The third one is Timarkin autolytic catastrophic Meniere's disease. We will try to go from one to another. Atypical Meniere's disease. It is a term used to describe the disease in which the patient complains of some, but not all classical triad of the symptoms. So that is probably cochlear hair drops or vestibular hair drops has been mentioned, where there is a predominant cochlear symptoms in one individual and other people will have a vestibular symptom. So under the entity Lermois syndrome, which is another variant, is a term describing the characteristic sudden onset of the sensation of the hearing loss, which improves during the or immediately after the attack of vertigo. So this is one more variant, Lermois syndrome. They call it as a reversal of fever Meniere's disease. But there is a sensory neural component which improves during or immediately after the vertigo. So hearing loss is the first one to appear. Third one is Tumarkin autolytic catastrophic Meniere's disease. It is also known as drop attacks of the Meniere's disease. It is characterized by abrupt falling attacks of the individual, brief duration without loss of consciousness. It must be distinguished from drop attacks of the children, that is called petit mal variant. So what is the epidemiology? In the epidemiology, the incidence of the Meniere's disease varies worldwide. In Great Britain, in 1954, Cawthorne and Hewlett conducted a study and reported the incidence of 157 cases per 100,000 cases, that is 1 lakh individuals. So in 1968, Harrison and Naftali reported an incidence of 100 cases per 1 lakh population in UK. In Sweden, the study showed an incidence of 46 cases per 1 lakh population. In France, the incidence was found to be only 7.5 cases per 1 lakh population. In Africa, the diagnosis of the Meniere's disease is very, very uncommon. So there is a global distribution is there, but difference in its incidences. This is the observation by epidemiologists. So what is the gender predominance? In Sweden, the female predominance incidence in female is the ratio of 3 to 2. and some others could not found any difference in prevalence between the males and females. What is the age incidence? The disease most often begins before the age of 60 years. The noticeable peak in incidence is the fifth and sixth decades. Familial factors. A positive family history of the disease was found in 20% of the cases. The inheritance appears to be multifactorial. What is the classification? It has been mentioned as a primary type and secondary type. Secondary type means in this secondary to some other diseases, it is manifested, like your hypothyroidism and other thing. We will go on talking about it in course of time. Primary disease, that means usually we don't know the cause of it, but it is the primary type. It has been mentioned. Primary Menieres disease, there are some sort of genetic factors also contribute. Several studies reported familial tendency in 14 to 20% of the patients with Menieres disease. It is suggested that autosomal dominant is the mode of transmission with abnormal gene on chromosome 6. There are anatomical factors. A small vestibular aqueduct is also a small endolymphatic duct, and the sac were blamed to be disease causing factors. So that means it will lead to accumulation of the endurance, thereby it will go for hydrops changes. The next one is trauma. Head trauma may produce biochemical dysfunction in the cells of the membranous labyrinth, or it may simply release debris, which will block the endolymphatic duct and sac causes symptoms. That means ultimate result is extension of the endolymphatic sac, resulting all the cardinal manifestations. So what are the even some sort of viral infection has been attributed, damage to the endolymphatic sac and duct by the neurotropic viruses has been proposed as etiological factor. Next is allergic manifestations. The target organ being your inner ear. An association between allergy and Meniere's disease has been noted in many studies, but it is not well established. Autoimmunity. Autoimmunity is a causative factor, has been seriously considered in Meniere's disease. The endolymphatic sac was shown to contain the immunoglobulins and lymphocytes, which are characteristic of autoimmune diseases. Immunoglobulins are found to be deposited in the walls and luminal fluid of the endolymphatic sacs in patients with Meniere's disease. Psychosomatic and personality factors. Some others propose that psychiatric stress in childhood and obsessional personality may lead to the Meniere's disease. But subsequent reports suggested that the psychological features are the result of the disease rather than the cause of the disease. What is this secondary endolymphatic hydrop? It is secondary to some other diseases. This is being mentioned as abnormal metabolic and endocrine states, hypo and hyperglycemic states, hypothyroidism, and defect in pituitary adrenal axis can result in hearing impairment and vestibular dysfunction, which are components of the Meniere's disease. Syphilis also can contribute. Syphilitic osteitis of the aortic capsule can cause obstruction to the endolymphatic duct and produces symptoms similar to the Meniere's disease. Next comes is your chronic otitis media. The bacterial toxins in the CSOM can diffuse into the inner ear through round window membrane and can cause sensory cell degeneration, causing impairment of the situation function and resulting Meniere's disease. What are the viral infections? Subclinical infection by measles and mumps viruses leading to viral labyrinthitis can result in unexplained sensory neural deafness and delayed endolymphatic hydra. Autosclerosis also can give rise to this finding. In autosclerosis, there may be physical impingement of the autosclerotic bone on vestibular aqueduct or biochemical alteration in the perineum and endonyms, resulting in symptoms similar to the Meniere's disease. Abnormal fluid balance. Abnormalities in fluid and electrolyte balance can precipitate symptoms of the Meniere's disease. So let us go into the pathophysiology. It is a little bit of interesting situations. If you understand the pathophysiology, you can think of planning for a treatment. So in this pathophysiology, the basic pathology of Meniere's disease is endolymphatic hydrops. Other name for Meniere's disease is endolymphatic hydrops. The distension of the endolymphatic space occurs in the expense of the perilymph. 60% of the cases, saccule is bulged and rests against the footplate of the stapes. So always you have to remember, stapes is closely related to the saccule of the inner ear. So in 40% of the cases, endolymphatic space is bulged in the region of the helicotroma, resulting low frequency hearing loss. About one third of the cases, the bulge extends into the horizontal semicircular canal, resulting vestibular symptoms. This is a sort of representation mentioning about how the inner ear looks in normal ear and how it is seen in Meniere's disease ear. You will very obviously see your labyrinth. That means your inner ear is bulged. The volume is increased. So thereby, if the vestibular component is enlarged or if not bulged, you will see vestibular component. Or if the cochlear component is also affected, you will see cochlear symptoms. This is the diagram showing the dilatation of the endolymphatic compartment of the cochlea in Meniere syndrome. On your left side, you are seeing normal organ of Corti and your inner ear. It has got a sort of scala tympani, scala vestibuli, and scala media. And this scala media, you got a organ of Corti, and thereby, in the case of picture B, you can see a distended scala media, and thereby your membrane, that is one is your basal membrane is in the resting organ of Corti, whereas rhesus membrane is getting distended, and thereby the scala vestibuli and scala tympani has got a perineum. Scala media has got a endolymph. When there is a distension, your rhesus membrane will get ruptured. And there is a mixture of perilymph and endolymph. It is been attributed to the result of the symptoms. There is a sort of imbalance or if not difference in the sodium, potassium, and calcium and chloride ion normalcy leading to these symptoms. Perilymph has been mentioned as a extracellular, endolymph has been mentioned as intracellular uh, fluid comparison. And when the middle ear air pressure is increased, the footplate of the stapes is pushed in and causes symptoms like vertigo, nystagmus, and tonic deviation of the eyes. This is known as Hennebert's sign, and also commonly seen in your syphilis, that is hypermobile footplate. It also explains the Turio phenomenon. It is the subjective experience of the imbalance and nystagmus also seen when the individual is exposed to loud noises and low frequency noises. The conditions are seen in long-standing Meniere's disease. So definitely, when the patient is exposed to loud noises, they get the sensation of the giddiness. This is one of the things you have to keep in mind. Circulation of endolymph takes place in both longitudinal and radial directions. So the longitudinal flow starts with the production of the endolymph in stria vascularis of the cochlea, the circulating via scala media and ductus reunions reaches the saccular and utricle. Elimination occurs through the vestibular aqueduct and the endolymphatic sac. It is the absorbed into CSF of the posterior fossa via endolymphatic sac. This is under longitudinal flow. These are the various theories have been put forth. Radial flow, the endolymph starts from the production of the dark cells in the uh, with local absorption. Disease occurs when there is a excessive production or decrease in the absorption of the endolymph. The end result is accumulation leading to distension, leading to the symptoms. Another explanation for symptoms of Meniere's disease is rupture of the hydropic membrane, membranous labyrinth, resulting mixture of the perilymph and endolymph. I just have to tell you. This leads to the sustained depolarization and inactivation of the hair cells and neurons of the eighth nerve, producing signs and symptoms of the Meniere's disease. Subsequent healing of the rupture and return of the endolymph and perineal barrier would result in restoration of the normal ear function. Chronic repeated ruptures and healing of the membrane, that is resonance membrane, of the labyrinth result in progressive and irreversible deterioration in auditory and vestibular function. What are the clinical features? The Meniere's disease is characterized by episodic attacks of the vertigo, rotatory vertigo, with tinnitus and ipsilateral hearing loss. So this hearing loss is because of chronic effect on the hair cells, resulting progressive hearing loss. Oral pressure and fullness in the affected ear or in both ears is common associated complaint. This is one more added symptom to the earlier triad. The attacks of vertigo may be preceded by a aura or oral fullness, increasing tinnitus and hearing loss. In some patients, symptoms may occur without any warning. Really, one ear may be affected. Later on, after some time, both ears can be affected. But really, we cannot predict the progress of the disease. That's why we need to go for a periodical evaluations. In the beginning, in our audiogram, it shows low frequency hearing loss. Later on, it will go to the mid frequencies, ultimately it will go high frequencies. Later on, it stabilizes. That's the usual progress of the hearing in individuals. Vertigo. Vertigo is episodic and associated with vertiginous symptoms like nausea and vomiting. There may be visual blurring and nystagmus. In some cases, vertigo is accompanied by pallor, diaphoresis, nausea, vomiting, and diarrhea. And that means GIT symptoms. And tinnitus, it is always present during the attack. It may be present between the attacks also, and it may be continuous or intermittent. The tinnitus is louder in the initial stages of the disease. It becomes softer as the hearing improves. Oral fullness. The oral fullness or pressure sensation limited to the affected ear. Some patients may feel pressure in the head and neck during the attacks. And some sort of psychosomatic effects have been mentioned. The disease may produce psychosomatic disorders like agoraphobia due to frightening vertigo, and this is more common in elderly individuals. So, what are the investigations supposed to be done? So, in the assessment of the cochlear function, the pure audiometry will demonstrate a flat audiogram in most patients. But I already told you, initially the low frequencies are lost. Later on, it will go to mid and finally high frequencies. In some cases, fluctuating sensory loss may be seen. Most fluctuations are seen in the range of 250 to 1000 Hz. Recruitment can be elicited by tests like binaural loudness balance test and estimation of the loudness discomfort level and short increment sensitivity, as otherwise called as CC, and Fowler's alternative ABLB, that is alternative binaural balance test. There are the few audiological tests you have to do to assess the cochlear function. Speech audiometry may show some normal speech discrimination scores. Electrocochleography, that LACOG, is the best existing objective test for Meniere's disease. It measures the electrical events generated either within the cochlea or primary efferent neurons. It includes cochlear microphonics, potential estimation, estimation of the summation potential of the cochlea, and compound action potential of the cochlea. That's why we call it as a ratio of the summation potential with action potential. And further, some tests can be seen to know the reversibility of the disease. In the earlier cases, you get a reversibility that can be identified by means of doing the glycerol test. When the glycerol is given in high doses, it is incompletely metabolized and acts as an osmotic diuretic. This is the basis for conducting the test. This results in reduction in the endorphatic drops and intralabyrinthal pressure, it will produce significant improvement in hearing thresholds in the meninges. Glycerol can be given orally or intravenously. Intravenous route is preferred. Assessment of the vestibular function tests. The test what we do is caloric tests. Most patients with Menieres disease demonstrate hypoactivity, vestibular ocular reflex, and caloric stimulation of the labyrinth. So that means the vestibular system got affected, hyperresponse will be there. Next comes the furosemide test. The test involves giving the patient a diuretic agent and measuring the changes in the caloric response. A significant improvement will be noticed in vestibular functions. Next comes with your vestibular spinal reference tests. These include various neuroautological tests like giant stepping tests, Romberg tests, Unterberger's test, dynamic posturography, and they will be significantly affected in the case of Meniere's disease. There is one more test we call the craniocorporography. It also assesses the vestibular spinal reflex test. What is the treatment available? This is a medical treatment as well as surgical treatment available. There is no cure for the disease at present, and the precise etiology of the disorder is not known. Only symptomatic treatment is available. Under the heading of medical treatment, symptomatic relief of the acute episode is brought about by labyrinthine sedatives. The following labyrinthine sedatives are widely used. One is phenothiazine, that is prochlorperazine and perfenazine, and antihistamines like cinnarizine, cyclazine, dimenhydrinate, and promethazine and meclizine hydrochloride. Benzodiazepine like diazepam or lorazepam has been tried in combination with labyrinthine sedatives. Benzodiazepine reduces the acute vestibular nuclei and also relieves the anxiety, which is very, very important and confusing to the patient. They are associated with this attack. That's why benzodiazepine has been added as a adjunct treatment. Prophylaxis between the attacks. You can counsel to reduce the salt intake and also diuretic therapy. Diuretic therapy will be reducing endolymphatic volume and pressure to prevent the attacks. Recently, central acting calcium antagonist, that is flunarizine, was found to be effective against Meniere's disease. Vasodilator drugs like betahistine, that is selective labyrinthine vasodilator, and papaverine, which is widely known, and amyl nitrate, nicotinic acid, etc., also be tried as prophylactic treatment. Infusion of low molecular weight dextran and inhalation of carbogen, that is 95% of the carbon dioxide and 5% of the oxygen, which will improve inner ear blood flow, are also being tried. Recent evidence that Meniere's disease may have autoimmune etiology led to use of steroids and cytotoxic drugs in the treatment as a medical management. The surgical treatment is also to be kept in mind. Surgical treatment is indicated to patients who fail to respond conservative enough medical treatment. There many procedures have been recommended or being practiced involving the preservation of the hearing and vestibular function. Decompression of the endolymphatic sac by removing a small bit of bone, overlaying it, and adjacent posterior fossa dura is one of the such procedures. Another procedure of increased drainage of the endolymphatic opening, sac, and creating a endolymphatic sournoid fistula. These are nothing but shunt procedures. And procedures involving the preservation of the hearing and ablation of the vestibular function. So it is very important. We cannot expect to lose hearing. Thereby, more focus is maintained on hearing preservation. The chemical vestibular function tests, vestibular function can be sacrificed. That means giddiness can be controlled. Chemical ablation of vestibular function by intratympanic injection of the streptomycin or gentamicin is one of such procedures. Non-chemical ablation of vestibular end organ by ultrasonic irradiation is another option. Selective selection of the, or if not section of the vestibular component of athener is yet another procedure. Thereby your hearing is preserved. The procedures involving the ablation of the hearing and vestibular function is nothing but removing the entire labyrinth, that is called total labyrinthectomy. So thereby we are losing vestibular function as well as losing the hearing function. So when we want to go for a maintaining the hearing, we have to go for a selective procedure only focusing on the vestibular component. Through transcanal or transmastoid approach, you can do total labyrinthectomy. Another procedure is translabyrinthine vestibular pneumonectomy is also recommended. Cochlear implant has got its role. Recently, UPS 22 channel cochlear implant has been tried in patients with Menieres disease after ablation, thereby get back your hearing because your cochlear nerve is intact. That is being practiced. Thank you.